Welcome to our presentation on hypertriglyceridemia led by Dr. Adebola Adetiloye. Today, we'll explore the overview, complications, and management strategies for this condition. Let's delve into the complexities of hypertriglyceridemia and its impact on health. Hypertriglyceridemia affects about 25% of U.S. adults. It's prevalent in individuals with obesity, diabetes, and metabolic syndrome. The condition can be primary, due to genetic factors, or secondary, influenced by lifestyle and other diseases. Risk factors include age, sedentary lifestyle, and high carbohydrate intake. According to National Cholesterol Education Program Adult Treatment Panel 3, hypertriglyceridemia is classified into borderline high, and very high. According to Endocrine Society, it is classified into mild, moderate, severe, and very severe. Understanding these classifications helps in effective management. The etiology of hypertriglyceridemia includes primary causes like familial hypertriglyceridemia, familial combined hyperlipidemia, familial dysbeta-lipoproteinemia, familial chylomicronemia syndrome, and polygenic etiology. Secondary causes include poorly controlled diabetes, hypothyroidism, nephrotic syndrome, medications like steroids, and alcohol use. Complications can be severe, including acute pancreatitis, cardiovascular disease, and non-alcoholic fatty liver disease. Recognizing these causes and complications is crucial for prevention and treatment. Clinical features of hypertriglyceridemia often include asymptomatic cases discovered during routine checks. Eruptive xanthomas and lipemia retinalis are visible signs when triglyceride levels are high. Acute pancreatitis is a serious complication, presenting with severe abdominal pain. Early detection and management are key to preventing these outcomes. Evaluation of hypertriglyceridemia involves a fasting lipid panel and ruling out secondary causes. Genetic testing is crucial for familial chylomicronemia syndrome, especially in severe cases with eruptive xanthomas and lipemia retinalis. Identifying cardiovascular risk and signs of pancreatitis aids in comprehensive assessment and tailored treatment plans. Management of hypertriglyceridemia focuses on lifestyle modification, pharmacologic therapy, and controlling secondary causes. Weight loss, dietary changes, and increased physical activity are essential. For hypertriglyceridemia, dietary changes should include reducing intake of refined carbohydrates, added sugars, and alcohol, which can raise triglyceride levels. Patients should limit total fat intake to 25 to 35% of daily calories, with less than 7% from saturated fat, and prioritize healthy fats such as omega-3s from fatty fish, flax seeds, or walnuts. A high-fiber plant-based diet with whole grains, vegetables, and lean proteins further supports triglyceride reduction and heart health. Alcohol should be avoided if triglyceride level is above 500 mg per dl. It is advised that dietary monitoring and follow-up ensure sustained management and prevention of complications. Pharmacological management includes statins, fibrates, omega-3 fatty acids, and niacin. Statins are first line for elevated ASCVD risk, while fibrates are effective for severe cases. Omega-3s and niacin offer additional benefits but may have side effects. New therapies are emerging for genetic or refractory cases. A stepwise approach to managing hypertriglyceridemia involves assessing triglyceride levels and estimating ASCVD risk. The primary goals are reducing ASCVD risk and preventing pancreatitis. This structured approach ensures targeted and effective management strategies. The 2021 ACC Expert Consensus provides a decision pathway for managing ASCVD risk in hypertriglyceridemia patients. It emphasizes ruling out secondary causes, optimizing diet, and considering statin therapy based on risk assessment. This comprehensive guide aids clinicians in making informed treatment decisions. For triglyceride levels between 150 to 499 mg per dl, the goal is cardiovascular risk reduction via statin therapy. Lifestyle changes are recommended for low ASCVD risk, while statins are first line for higher risks. EPA-only omega-3 could be added for cardiovascular benefits, especially in patients with high ASCVD risk and triglyceride levels above 200 mg per dl. This approach balances lifestyle and pharmacologic interventions for optimal outcomes. With triglyceride levels of 500 to 999 mg per dl, the focus is on reducing cardiovascular risk and preventing pancreatitis. Fibrates or omega-3 fatty acids are preferred in patients without ASCVD risk or low risk. Both can be combined if triglyceride levels remain high. For patients with high ASCVD risk, add statin therapy. Statin plus omega-3 fatty acids or statin plus fibrate can be used. Fenofibrate is preferred over gemfibrozil because it has a much lower risk of muscle toxicity when combined with statins, making it safer in patients who need combination therapy. It also has fewer drug interactions and more convenient dosing. If triglyceride remains high, statin plus omega-3 fatty acids plus fibrate can be combined. Dietary fat reduction to less than 20 to 25% calories is also crucial. This strategy addresses both immediate and long-term health risks. Triglyceride levels above 1,000 mg per dl are a medical urgency. Immediate dietary changes and medication adjustments are necessary to prevent pancreatitis. Hospitalization may be required. Management of triglycerides above 1,000 mg per dl focuses on preventing pancreatitis and lowering triglyceride levels rapidly. Initial steps include a very low-fat diet, below 15% of calories from fat, eliminating alcohol, and managing secondary causes like uncontrolled diabetes or medications. Fibrates are first-line pharmacologic agents, often combined with omega-3 fatty acids, EPA plus DHA, at 2 to 4 gram per day. Statin is indicated if established ASCVD or high ASCVD risk. Insulin can be used if hyperglycemia is present, as it helps lower triglycerides. For patients with familial chylomicronemia syndrome, FCS, the recently FDA-approved olezarsen, brand name Tryngolza, an antisense ApoC3 inhibitor, offers targeted therapy, reducing triglycerides by 50 to 60%. Management of pancreatitis, secondary to hypertriglyceridemia, begins with supportive care, including bowel rest, NPO, IV fluids, and pain control. Rapid triglyceride lowering is critical and may involve insulin infusion, even in non-diabetics, especially if levels are above 1,000 mg per dl. In severe or refractory cases, plasmapheresis can be used to quickly reduce triglyceride levels. Once stabilized, long-term management includes fibrates, omega-3 fatty acids or statins, if indicated, along with dietary changes and weight loss. Avoidance of alcohol and strict control of diabetes and secondary causes are essential to prevent recurrence. A summary of drug classes for hypertriglyceridemia management includes statins, fibrates, omega-3 fatty acids, niacin, and insulin. Each class offers different levels of triglyceride reduction and is chosen based on the patient's specific needs and risk factors. Understanding these options aids in personalized treatment planning. Statins are indicated in hypertriglyceridemia primarily to reduce ASCVD risk, especially when triglycerides are above 150 mg per dl in patients with existing cardiovascular disease, diabetes, or high ASCVD risk. They are also used when triglyceride levels are 200 to 499 mg per dl with elevated LDL cholesterol, or in combination therapy when triglycerides above 500 mg per dl to lower overall cardiovascular risk. While statins modestly lower triglycerides, 10 to 30%, their primary benefit is LDL reduction and plaque stabilization. Common adverse effects include myalgias, elevated liver enzymes, and rarely rhabdomyolysis. Statins may also slightly increase the risk of new-onset diabetes, especially at high doses. Fibrates, or PPR-alpha agonists, are the most effective class for lowering triglycerides, reducing levels by 30 to 50%. They are indicated for triglyceride levels above 500 mg per dl to prevent pancreatitis. Adverse effects include myopathy, especially with statins, elevated liver enzymes, gallstones, and renal function impairment. Monitoring renal function and liver enzymes is essential due to potential adverse effects. Omega-3 fatty acids include eicosapentaenoic acid (EPA) and docosahexaenoic acid (DHA), with prescription forms used for triglyceride management. Icosapent ethyl, EPA only, has shown cardiovascular event reduction in the REDUCE-IT trial. Omega-3 acid ethyl esters, EPA plus DHA, are more potent at lowering triglycerides, but may increase LDL due to the DHA component. Typical dosing is 2 to 4 grams daily, reducing triglycerides by 25 to 45%. EPA-only formulations like Vascepa are preferred in patients with ASCVD risk due to their cardiovascular benefit without raising LDL. Niacin, or vitamin B3, reduces triglycerides by 15 to 30% and raises HDL. However, its use is limited by side effects like flushing and hepatotoxicity. It's generally reserved for patients not responding to other therapies, highlighting the need for careful consideration in its application. Olezarsen, brand name Tryngolza, an antisense ApoC3 inhibitor, was FDA approved in December 2024 as the first treatment for familial chylomicronemia syndrome, FCS, reducing triglycerides by 50 to 60%. Volanesorsen, a similar antisense therapy, lowers TGs by up to 70% but lacks FDA approval due to safety concerns. Pemafibrate, a selective PPAR modulator, is under investigation for its potential benefits with fewer side effects. ANGPTL3 inhibitors like evinacumab are being explored for genetic forms of dyslipidemia. These agents are considered for patients with genetic or refractory hypertriglyceridemia, particularly with severely elevated TG levels. Monitoring and follow-up are crucial in managing hypertriglyceridemia. Regular lipid panel checks, monitoring for side effects, and reinforcing adherence to lifestyle changes ensure effective long-term management. This proactive approach helps maintain health and prevent complications.